Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Ryan Topping. Today's episode features expert discussion of CELMoD therapy for multiple myeloma, including mechanism of action, available clinical data and ongoing trials, and future implications. This episode is part of a larger educational program titled CELMoDs in Myeloma: What's Here, What's Next, and What's on the Horizon. For more information, along with a link to the larger education program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say on this important topic.
What are the unmet medical needs, however, in 2025? And I think there still remain some. Patients who have or develop high-risk disease, patients who present with true extramedullary disease, not paramedullary disease, but true extramedullary disease of presentation, despite everything that we throw at them, don't have great long-term outcomes. I think frail patients remain a challenge, and the idea of quads or even 5 drugs as part of the combination simply isn't practical or realistic. So thinking about ways to reduce the dose of many of the drugs we use and get patients into deep responses that translate into improved outcomes, I think is an important goal. Patients with 3 or more prior lines of therapy, we know that a number of patients early on now are receiving BCMA-directed therapy. What do we do for those patients who are progressing on those kinds of treatment options? And finally, patients who are resistant or intolerant to major targets, IMiDs, PI, CD38, BCMA, and GPRC5D. What do we do for those patients? I think with the approval of BCMA and GPRC5D-directed therapy, we were really excited because we had things to offer. But now we've got a wave of patients that are exhausting those options, and what are new potential therapeutics that we can offer them? So what are the new options? Well, we've got CELMoDs, and we're going to talk about that a little bit today. We've got new CAR T-cell targets. We've got new antibody-drug conjugates. We have tri-specific antibodies. So you're going to hear a lot about cereblon and cereblon binding, particularly with the CELMoDs. And what I want to really focus on is the idea of how this class of agents are really different from the IMiDs, lenalidomide, pomalidomide, or even the precursor for those drugs, thalidomide. And they really have to do with binding affinity and changes in the conformation of cereblon itself when you bind. And this closed conformation really leads to more rapid downstream degradation of those transcription factors, and actually in some cases leads to irreversible downstream targeting of some of those transcription factors as well. And while I think we're really focused on killing the myeloma cell, to me, this is the real added value of the CELMoD class. It's the ability to make your immune system better. And you may hear this from me or my colleagues throughout talking about the IMiDs are effective, but CELMoDs to me are like cappuccino for T cells. You can take an exhausted T cell and wake it up. And that to me really is important when we think about CAR T-cell collection, post-CAR T-cell infusion, or T-cell engagers enhancement by combining with the CELMoD class of agents. And you can see that described for both iberdomide and mezi. So what are we going to talk about in the next few moments? We're going to talk about relative additions to our treatment using the CELMoD class of data. You're going to hear clinical data alone, as well as potentially in partnership. What does this class offer over what we already have? And finally, how do we really think forward about the next 5 years about using the CELMoDs in partner with many of our existing immune targets to make all of these therapeutic options far more effective?
Just to remember, unfortunately, I got my 25-year ASCO from fellowship. I've been a member. So I remember pomalidomide when it came out as a with those 1 trial. So that was a huge step forward. And I have to say, it actually took a long time now for us to get to these CELMoDs in terms of a newer, more potent type of immunomodulatory drug based really now on a much deeper understanding of cereblon, right? Because when Len came out, we didn't really understand why it worked. And now we really do, and we can exploit that knowledge as well to develop more potent drugs. And as I said, part of that potency is in terms of its enhanced affinity to cereblon. And you can see the potency, again, 20 times higher than lenalidomide and pomalidomide, which also in a way says, okay, perhaps you don't need as high doses, so you can also reduce some of the other toxicities we see with those drugs. We see synergy in terms of preclinical models as well, which is important. We've seen it with ibermezzi, its activity in patients who are resistant to pomalidomide, and which is, a huge need for us because, again, we can talk about this. Yes, we have T-cell therapies, but there are patients who have exhausted T-cells, poor T-cell function, pace of disease that makes T-cell therapy not an immediate next option for them. So again, even for these POM-resistant patients, new options are desperately needed. To me, this is probably the most interesting thing because this is where you can say, how am I going to ultimately use this drug? So we have a trial right now going at City of Dr. Murray Janakiram is running it, using mezigdomide as CAR T maintenance, really, again, for this idea of continuing to improve T-cell health. So I think that's a big space. And who's going to touch on the maintenance post-transplant space? Again, I think there you're using it both for its direct anti-myeloma effects, but also for its T-cell effects. Again, so immune fitness being a big part of preventing myeloma relapse. So in conclusion, CELMoDs clearly lead to potent protein degradation. They can overcome Len and POM resistance. They can improve T-cell fitness. So we really need to see what is their best partner, right? So we have multiple trials right now with bispecifics and pomalidomide. Our trials planned are in early phases using some of the CELMoDs plus these bispecifics. Clearly studies going on with CELMoDs plus CAR T cells. So I think all of these are avenues where they can continue to improve the drugs we have now in terms of the T-cell engagers, make them better, target these high-risk populations as well.
So my job is to actually now show you some of the data that we have on these CELMoDs, and maybe also touch a little bit on some of the studies that are currently accruing and that are planned as well. But I do want to state that there are currently no FDA-approved CELMoDs for multiple myeloma. So everything we're discussing is clinical trials, okay? So just remember that. So there are 3 CELMoDs, as you heard, in development, although one technically is not a true CELMoD, but I put in the same category that will work via cereblon modulation or inhibition as well. So we have iberdomide, mezigdomide, and sensidomide. So we'll talk about just the initial proof of activity of each one of these. So iberdomide was tested in the CC220 MM001 study, and mezigdomide in the 92480 MM001, and sensidomide in the 1101 study. So we'll start with iberdomide. So CC220 MM001 is a multi-cohort study. So it's basically, this is in patients who are relapse refractory, had prior IMiDs, prior PIs, prior anti-CD38s. And so you see that the several cohorts, but the first 2 cohorts, cohort A and B, are iberdomide and also iberdomide with Dex. And as you know, Dex in myeloma is like water, right? So everything goes better with a little bit of Dex. So that is sort of almost considered like a single agent, especially with the IMiDs and now also with the CELMoDs. And so just kind of keep that in mind. And then so that was the dose escalation, but really it was the cohort D, which was the recommended phase 2 dose with Dex that sort of kind of showing us the true activity of this molecule. In terms of toxicity, I think this is actually what's going to be sort of the theme of these drugs, is that as part of the mechanism of action, we expect neutropenia. That is actually, unfortunately, comes with the way these drugs work. So as you see here, you see neutropenia in 60% of patients, grade 3 of 25%, grade 4 of 19%. The other cytopenia is much less. But I think what's even more interesting is that when we look at the non-hematologic toxicities, we actually are seeing much less than what we're used to with the IMiDs. So if any of you have treated patients who are on Lin maintenance, for example, you know that a lot of those patients complain of fatigue, a lot of them develop diarrhea. And so you're seeing that even though those are reported here, there are very low percentages. And I think that's actually something that we would expect based on the fact that these drugs are so specific to cereblon. And it's one isomer only that presumably has the activity, whereas the other isomer is the one that often has the off-tumor or off sort of target side effects. And so we're not surprised that perhaps we're seeing that there's less toxicity with some of these drugs. The neutropenia is common, but as you can see, infections are still common in this population as we expect. But really, the grade 3, grade 4 infections are not there, as we're seeing right now with some of the bispecifics and CAR-Ts. So this was the data in this cohort. So our response rate of 26% with a clinical benefit rate of 36%. And if you add stable disease, you see we're going up 79%. The PFS, modest, but 13.1 weeks. And I remind you that these are the numbers that we're seeing or we saw with pomalidomide, that we saw with belantamab mafodotin as single agents when they were actually reported, including daratumumab as a single agent. And in the past, these are the kind of data that normally would get a drug approved. That's until some people started working on CAR-Ts and bispecifics, which are giving much higher single agent response rates. And so now this data doesn't look as good, but I think this data actually looks quite good if you think about the patient population we're talking about. What about mezigdomide? So mezigdomide was tested in the MMO1 study as well. And again, dexamethasone, it's just part of it. But this is basically, again, similar population, greater than 3 prior lines of therapy, prior LEN, POM, PI, anti-CD38 antibodies. Patient received mezigdomide with dexamethasone. Of course, the single agent was done and eventually with combination. And so when we look at the toxicities, you see very similar data, except that maybe more cytopenia, especially more neutropenia. And we would expect that this is actually probably a little more potent drug than iberdomide. And so the neutropenia, again, 77% with a high percentage of grade 3s and grade 4s. And again, this is expected based on the mechanism of action. Now, here when we look at the actual response rates, you see the overall response rate of 40%, which is actually quite impressive again in this patient population. Patients achieving CRs and VGPRs, again, also impressive. If you look at patients who have prior anti-BCMA therapy, 50% overall response rate. So again, very active drugs in a very refractory patient population with a median PFS of about 4.4 months. Duration of response is 7.6 months. Dr. Lonial said we will see data on cemsidomide, but I forgot that he's an author on this trial. So we actually have data that's been presented. He's in so many things that he forgets these things now. But so we do have a little bit of data with cemsidomide. Again, a very refractory population. Again, single agent, and then with the addition of dexamethasone. I'm going to show you the cemsidomide dexamethasone data. Toxicity-wise, again, back to the neutropenia as being the main toxicity. And so with this, if you go all the way to the very right, you see that for all dose levels, the overall response rate is 26% and the clinical benefit rate of 40%. But if you concentrate on the higher dose, which is the recommended phase 2 dose, or at least close to the recommended phase 2 dose of 75 micrograms daily, you start seeing a response rate of 36%, CBR of 45%, very similar to what we're seeing with the others. So as Dr. Krishnan said, these drugs are not for single agent use. They probably are going to be best in combination. So we actually do have some initial combination data as well. So we'll go back to iberdomide first and back to the MMO1 study. And you see the cohorts in the blue now are the combination cohorts. And so you have iberdomide dex dara, iberdomide dex bortezomib, and iberdomide dex carfilzomib. And so, again, these are sort of proof of concept trials that may or may not lead to larger trials. Response rates, better, right? So again, a very refractory population. A lot of these patients were actually DARA exposed or refractory as well. We're seeing a real response rate of 46%. And we're even getting some patients with complete response rates. So based on this, cohort K looked at patients with iberdomide dex dara who are newly diagnosed, who are transplant not eligible or it did not go to transplant. So again, these are untreated patients. Look at these responses. So a response rate of 95%. And what's actually even nicer is that we're seeing a deepening of response. So from 7 months to 11 months to 14 months, you see that the green numbers or percentages are increasing, those with the CR and SCR rates. So quite a large proportion of patients who are achieving a complete response. And similar with MRD negativity, you see that patients, 38% of patients are MRD negative. If you just look at the patients VGPR better, we're looking at 43%. And then currently we also have a trial called the Excalibur Maintenance Trial, which is still accruing at this time. So patients who've had induction and had a stem cell transplant, and then for maintenance or before maintenance, they're randomized to either iberdomide or lenalidomide. And so this trial is ongoing, and obviously this will help us in terms of the ability for iberdomide to be useful in that setting. I personally, obviously this trial is it's sort of stalled a little bit because of now more data with the doublet as maintenance that has stalled some of the enrollment in the US. But lenalidomide still is an FDA-approved maintenance. And I think what I like about this study is that I think iberdomide, if the toxicity profile sort of kind of stands, I think lends itself better to a more prolonged use than lenalidomide. So we'll have to see. Maybe if less patients come off early, we should see an improvement. So more to come. And then we also have the Excalibur relapse refractory myeloma. So careful there, both are Excalibur, one's maintenance and one's relapse refractory myeloma. And this is randomizing patients to iberdomide, Dara-Dex versus Dara-Bortezomib Dex. And this study actually has now accrued completely. So we're just now waiting for the data. And if that's a positive study, perhaps that's the study that might get this drug approved. And then mezigdomide combination data, of course, exists as well. We have these phase 1 dose escalation trials with mezigdomide, bortezomib, dexamethasone, and mezigdomide, carfilzomib, dexamethasone, so different cohorts A and C. So here we see the data. I guess the response rates, if you look on the left, it's the MESI-VD, on the right is MESI-KD. You see overall response rate of 85%. And median PFS of 16 to 20 months, depending on which one we're looking at, which dose 0.6 versus 1.0, so both very active. And then when you look on the right, the MESI-KD, again, remember this is a more heavily treated population. You're seeing response rates of 85% with median PFS of 11 to 14 months. So, strong activity, I think, in these early combination data. And so we now have sort of that was the phase 1 dose escalation. Now we have actually also the expansion. And the expansion, you're really seeing that the overall response rate is keeping at over 80%. Again, with lots of high percentage of VGPRs and CRs, and ongoing. On the right, you see a lot of arrows to the right, which means those patients' responses are still ongoing. We now also have phase 3 data with from the successor trials. So successor 1 is basically taking that combination with bortezomib, dexamethasone in patients with 1 to 3 prior lines of therapy, and patients will be randomized to mezigdomide, bortezomib, dex versus pomalidomide, bortezomib, dex. So really pitting the mezi versus pomalidomide head to head in patients with 1 to prior lines of therapy. And this trial is ongoing. I actually don't know if this has accrued fully or not. I'm not. If anybody knows. And then successor 2 is basically the combination with carfilzomib that we showed you earlier, and that would be in patients with at least 1 prior line of therapy. Here you have to have a prior len and prior anti-CD38 as well. So again, these are patients who have seen or triple class exposed at least. And so it would be mezi, carfilzomib, dex versus carfilzomib, dex. And so this trial is actually still accruing at this time, although it's actually close to meeting its accrual.
Thank you, Dr. Berdeja. And so, Dr. Berdeja had talked about some of the trials he talked about use MRD as an endpoint. So in a way, I think he set the stage for, is that a valid endpoint now for us when we look at studies versus what we used to? So first, let's take a step back and talk about if we are going to use MRD as an endpoint in our trials, what do we want from it? Well, obviously, if you're going to use MRD, you need a test that's sensitive. You need it standardized, right? Dr. Lonial is going to tell me that his MRD test is better than mine. So you want it widely available. Cost efficient would be ideal, certainly, and reimbursed by payers. And ultimately, the proof in the pudding that you need it accepted by the FDA. So as you'll see, and I'll show you, and we're here at this meeting, there are trials now incorporating MRD testing. In fact, most studies including in the relapse setting, as we'll talk about, collect samples, report out MRD rates. Most of us, certainly in the upfront setting, when we think about therapeutic decision-making and our goals for our patients, our goal is sustained MRD negativity. Now, in the trials, and I think this is where now we finally have reached the last bullet point, which is these trials are now showing us that we can guide decision-making based on MRD positive and negative. And that's really ultimately where we want to be. And so we're finally seeing some hints, and you'll see one of those readouts on Tuesday at the myeloma oral abstract session. So I think that's very exciting for us. Now, are we willing to take MRD and really not wait for PFS anymore? So if you look at this meta-analysis, this was from Dr. Munchie that he published a few years ago of over 8,000 patients. He clearly showed both in the transplant eligible and transplant ineligible that MRD status correlated with PFS. I'm going to show you some of the data from ODAC as well. But first of all, why is that important? Well, because we've gotten better at treating myeloma, right? So PFS used to be, it's kind of hard to imagine, back in the day, PFS was 2-3 years. Now, if you see the trials in terms of quad induction plus transplant, you haven't reached a median PFS yet. So if you're trying to test new treatments, how are you going to use your benchmark if it's going to take over 8 years to show a statistically significant benefit if PFS is your endpoint? And of course, no one is willing, both from a drug development standpoint, but also from a patient care standpoint, right? That is too long to wait in terms of evaluating new treatments for patients. So now we have the data that Dr. Langren presented at the ODAC meeting looking at MRD and presenting the case, why should MRD be FDA approved as a surrogate endpoint? This was, again, meta-analysis using now subject-level patient data. And you can see about 8,000 patients here. Let's go into the details of those studies. But ultimately, this is probably the most important slide that I have to thank him for, that at the individual subject level association, you see that MRD correlated with progression-free survival, and for most cases also, in fact, with overall survival, both in the transplant eligible and transplant ineligible population. So the FDA, about 5 years ago, published their guidance on the consideration for use of MRD and what they would need to see to consider it a valid surrogate endpoint. And so they had to demonstrate the prognostic value of a surrogate endpoint for clinical outcome, and especially in terms of long-term clinical outcomes. So in April of last year, the ODAC had a meeting. I could say I think all the myeloma doctors watched it instead of Netflix that day. It was a very turning point, really, because there was a unanimous vote based on some of the data that I showed you from Dr. Langren's studies in favor of using MRD negative CR as an early endpoint in myeloma clinical trials. So, you can see here, this really moves the curve forward because now we can have a much earlier surrogate endpoint and accept that in terms of the drug development. So let me finish by saying, so did we get our MRD wish list where we have a test, next-gen sequencing, or flow that's sensitive? We have standardization with next-gen sequencing. We have it now accepted by the FDA. And now we have trials that have used it to guide clinical decision-making, the Perseus trial, the MIDAS trial, and hopefully in the future, the DRAMATIC study as well.
Thank you. So we're going to talk about a little bit in terms of future implications. So the real question is, where do iberdomide and mezigdomide fit in our current treatment paradigm? Both agents clearly have activity in IMiD exposed and IMiD-resistant patients. And one of the strengths that I see is the profile of adverse events and relative opportunities are slightly different. So I'm going to touch on a couple of other sort of basic slides, and then I'm going to turn to my co-panelists to really help us think about how we're going to think about using these down the road. So similarities, they're all oral. Demonstrated activity, it's being studied in earlier lines, combinations with other agents. Differences, Mezi really does have greater cereblon binding potency and actually almost induces 100% of the cells in a closed conformation, which we think has a better and longer effect on downstream effects. There's also one difference that I'm going to show you in a slide in just a moment. Iberdomide, however, may be a little bit more tolerable with lower rates of severe neutropenia. And Jesus did a great job summarizing the Iberdomide 001 trial. One difference when I show the adverse events is I put a box around all the zeros, showing very few grade 3, grade 4 adverse events, which I think really is different. We've got a smoldering trial with Iberdomide as a single agent, and we've had a couple of patients say, "Are you sure I'm getting the real drug? You told me there was no placebo here," because they don't feel the impact of the drug on their quality of life or day-to-day living. And I think all of us that have used Iber have had similar experiences with patients as well. What about thinking about it in the landscape of earlier lines of therapy? So for me, the fewer non-heme adverse events really makes it a great partner for many of our induction regimens. So that KID regimen that you showed makes a lot of sense to me, thinking about how to bring it earlier. And then the maintenance setting, I think, does make a lot of sense to me. And certainly at our center, we've not adopted DARE maintenance for everybody. So that trial is enrolling like gangbusters at our place because we're putting everybody that would normally get LEN. And then for Mezi, the context of high-risk cytogenetics, heavily pretreated advanced disease is really an exciting concept where patients with extramedullary disease may get benefit from the use of Mezi. And I'm going to skip through these because Jesus already showed them. So I'm going to turn to my panel colleagues here and say, in a perfect world where FDA approvals don't get in the way, Jesus, where would you think about these new CELMoDs and sequencing them, and where would you see them fit?
Yeah, you said there was no wrong answer. No wrong answer. I mean, I agree. I feel like Mezi is probably the stronger of the two, but it definitely comes with the price, as everything we do. So I really see Mezi as sort of the one that's going to be in combination when you're trying to get a patient into remission. They have bulky disease and they're progressing. I think a combination with Mezi makes the most sense to me. The Iber, because it's still a very powerful drug, but it does have that improved toxicity profile. And so I think when we're looking at combinations, just like you said, so like makes it pre-CAR T, we know that CAR Ts work really well. We know that the toxicity with CAR Ts is less when you have good control of disease. So if we're trying to not only sort of get your disease under control, but then use a drug that also may potentiate your T cells, I think as that holding therapy before you collect your T cells, that would be an ideal combination for you, where Iber in a combination will do that, and then also as a bridge.
Amrita? I guess my question really is more, would you be willing, because you made the point much better tolerated, so did you, to throw away LEN? And just wherever you were going to use LEN, I'm assuming you think that phase 3 trial is going to be positive in favor of Iber, right? So is that going to be our biggest paradigm shift? I think possibly, yes. Yeah, I agree with you. I think Mezi is more potent. I've been actually in a post-CAR T maintenance study, it's been quite well tolerated. I think we started far enough post-CAR T and we've not had, significant, obviously we don't start at full dose. So I think some dose modulation makes it fairly manageable. I would really like to use it in combination with either talc or teclistamab, right? The PFS of the T cell therapies, 11 months, or so. We really need to do better, and especially in that extramedullary disease category. So I think that's, to me, the most attractive place.
So I'm going to, and it'd be interesting to compare your Mezi post-CAR. Mm-hmm. I've got a cohort of, I think, almost 35 that I give POM to after CAR. Yeah. And just see what are the differences in PFS. Because I actually think this entire class is really effective. We don't have Iber Mezi, so I use POM just to give something as maintenance post-auto or post-CAR.
I do that too for the people who can't go on the trial.
Yeah. Also, you've got an internal cohort you could compare.
Yeah.
Yeah. Okay. I mean, I think that would be a really interesting.
And I have a few patients that were on the trial with ida-cel.
Yeah.
Followed by
Iber.
Where it was sort of your choice whether you wanted to. No, not Iber, with Len. This is before.
Oh.
So this is Karma 2.
Okay.
It was high risk patients, or patients who did not have, I forget which cohort it is, but basically who were like induction transplant, they still had disease, were able to get the CAR T, and then we were allowed as an investigator to give maintenance or not. And every patient that's gotten maintenance on that trial has not progressed. So it's actually very interesting. It's like an N of 8, and I think I have like 4 of those. So it's actually very intriguing, right? In that sense, that alone was sufficient to potentially make a difference.
Yeah. Yeah. So, Amrita, I'm going to come back and revisit your question about combining with T-cell engagers, because to me, the question is, do you continue them both indefinitely, or does the combination allow you to get to a point where you can stop one or both? And how would you think about it?
I would think about it as give the T-cell engager for a fixed duration, and then continue with Mezi as basic, or you can give a T-cell engager and then change the schedule, right? Because even some of these we're giving quarterly now. So that would be another ideal setting, right? Continue Mezi in between and then kind of reboost them. So both ways, I think what you try to do is prevent T-cell exhaustion, right? And I think those are good ways to do it.
I mean, the trials were, they were late relapse. So when they progressed, they didn't probably stick around long enough, and they'd all had LAN POM. So it's hard to do direct attribution.
Right. I mean, the maintenance trials and the frontline trials.
That's what
I mean, but I do think that is the only other unresolved question, right? In terms of helping us decide as well.
Yeah, I guess what I'd say is, particularly in the transplant setting with LEN maintenance, that number is really small. It's 2.7%. And so I think a lot is said about it and a lot is made up about it, but the real data is not that high, even with the melphalan signature that is often seen in patients who get high-dose melphalan.
Can I challenge Dr. Krishnan?
Sure.
Her comment.
Please do.
Mezi after TCE. So my only concern is, so you have now a patient on a BCMA bispecific who is very immunocompromised. Immunoinfections are very high. And now you're going to give them a drug that potentially can cause neutropenia. Are you worried about worsening the infection?
That is fair, because I was looking at your Mezi data and you had a 33% grade 3, grade 4, which is actually the same as what the trispecific is showing. So I do think it's fair. So I think this is not for everyone, but there are clearly, even at least in the bispecific space, patients where we know signal, right? To basically the EMD patients, right? And with Sagar's data in terms of EMD, I think those are patients who are willing to take some degree of risk to improve that PFS.
Yeah, I mean, I think part of that is why, unless they are functional high risk or they have extramedullary disease, I would probably favor Iber over Mezi in the partnership with a T-cell engager. So as we think about personalizing care, that might come into the equation a little bit.
Again, none of this is FDA approved. They're just musing.
We all do whatever we want. We all. So I'm going to, Jesus, I'm going to come back to you on the question I asked Amrita. If you're going to talk about combining with a T-cell engager, and it doesn't matter what flavor or what version you used, is your goal for the combination to do something different than the single agent, or to be able to shorten duration of one or both?
Both. So I think, the response rate of the TCE single agent is only about 60 to 70%, right? So there still is a large chunk of our patients that are not responding. So I think that's where I see a combination. We know the combination data looks much better in that sense. So again, getting that initial response is very important. But as we're seeing now with all of the TCEs, is once you achieve that remission, it is very safe to start sort of pulling back and decreasing the frequency. And I think that's where I see sort of the potential that you can actually even stop the TCE and maybe just continue, and I would actually do in my perfect world, I would do a limited duration of both, where I would use let's say Iber to stop the TCE and then give a certain amount of time after and then stop it as well.
Yeah. Yeah. And that's what I'm thinking too. I think
we as a group have used continuous therapy to do all the good stuff we've done in the last 15 years. But with the agents we now have, we may be able to get to a limited duration therapy world, and we're not going to know that until we test it. And in fact, in the new IMWG response criteria, there's going to be a definition of cure, and it means off therapy. And so we're going to have to get to that as we think about that more and more. Yeah.
Thank you, Dr. Berdeja, Dr. Krishnan, and Dr. Lonial, and many thanks to you, our listeners, for joining us. As a reminder, to visit the full program, CELMoDs and Myeloma, what's here, what's next, and what's on the horizon, please click the link in the show notes. Be sure to check back regularly for more episodes on important clinical care options oncology podcast topics.